So pleased to introduce our next speaker. Dr. Kurt Weiss is a associate professor at University of Pittsburgh. He's an orthopedic surgeon. He also runs a musculoskeletal oncology lab, which studies sarcoma metastatic potential. And she's affiliated with many things, MSTS, COG, you name it. But he's also a metastatic osteosarcoma survivor, which gives him, I think, really unique perspective in his role as both a clinician and a researcher. So excited. Okay,
Thank you. Yay. Thank you, Christina. And thank everybody for making me feel so welcome. My first ever SPAGN meeting. How do we
Let me take this. Sorry.
Okay, cool. Hey, thank you. The chances of me figuring that out are exactly zero. So, thanks everybody. As Christine mentioned, my name is Kurt Weiss. I'm at the University of Pittsburgh. I'm an osteosarcoma. I'm a sarcoma survivor, a sarcoma surgeon, and a sarcoma scientist. So I wear a few different hats in this community, and I'm delighted to be here. Let's see if that's going to work. Yay. My disclosures. I don't have any financial relationships with any implant companies or anything like that. I would like to disclose a friendship, which is Dr. Janet Pannock, who's sitting right over there. And Janet's a fascinating lady. She is the mother of an osteosarcoma survivor and has learned sort of firsthand that we don't have fantastic tools on how to have these very difficult conversations when it comes to bone sarcoma surgery. So as a consequence, she's devoted basically her entire professional academic life to helping us come up with better tools for having those conversations. And so when SPAGN approached me to give this talk, I kind of had an ace in the hole, and that was Janet, because I knew she was going to help me prepare some slides, and she was going to keep me from saying anything completely stupid. So thank you, Janet, and thank you for being here. We're certainly more than just bags that hold trauma, right? We're more than just a collection of our successes and failures, but certainly also who and what happens to us has a lot to do with what we do and where we go. So for example, if you take this very reductive example, if you take a kid and give them a horrible metastatic bone tumor and expose them to these teachers in surgery, Henry Mankin, Mark Goodman, Richard McGow, you might get yourself a musculoskeletal oncologist. The guy in the middle there, Dr. Mark Goodman, is actually a fascinating guy and is actually here in the room with us, just like Janet is. So Goody was my surgeon, and I started seeing surgery with him when I was 17 years old. And I finished seeing surgery with him after being his practice partner for 9 years at the University of Pittsburgh. And more than anyone else, Goody really sort of encouraged my curiosity of medicine, and then orthopedic surgery, and then orthopedic oncology. So if you have any complaints about me being alive or about me becoming a musculoskeletal oncologist, you can direct them to that guy right there. Okay. Similarly, if you take a kid and give them a horrible metastatic bone tumor and expose them to these teachers in science, Chris Evans at the Mayo Clinic, Jeannie Kleinerman at MD Anderson, Sean Connick here in Washington, and Steffi Osterreich at the University of Pittsburgh, you might get yourself a translational oncologist. I'll breeze through this. We all know it's rare, right? Most of human cancer are the carcinomas, lung cancer, breast cancer, prostate cancer. You get the idea. About a quarter are the leukemias, lymphomas, multiple myelomas, and coming in here soaking wet at 1% are the sarcomas. These are malignancies that arise in the connective tissues, the stuff that makes up our skeleton. Many examples, almost, as we've heard many times today, 100 distinct histologic subtypes, but what makes them similar is much more important than what makes them different. the thing that makes cancer cancer is that it doesn't want to stay put, it wants to go to other places and cause trouble. We call that a cancer's metastatic potential, its ability to travel. Sarcoma seems to have a pretty limited passport. Sarcoma likes to go to the lung, and the lung. Now, there are histologies that go to the lymph node and lung. They are few and they are weird, but for the most time, what we're talking about with sarcoma metastasis is the lung. I'm going to focus mostly on osteosarcoma and Ewing sarcoma for the purposes of this discussion, with one huge exception, which I'll get to in a couple of slides. These are both predominantly diseases of the young, the first 2 decades of life, although osteosarcoma seems to have a second spike later in life. And Dr. Grohar and I were just talking about Ewing's, the unexpectedly high number of Ewing sarcomas that happen after the age of 18. You can see here on this Dalenogram from Dr. David Daleen, who's a pathologist, that most osteosarcomas are going to happen around the knee, the distal femur or the top part of the femur bone, the proximal tibia or the top part of the shin bone, and the proximal humerus. Those are the 3 main sites. Again, most metastatic diseases to the lungs. Ewing sarcoma, the second most common primary bone malignancy. James Ewing might have finished at Sloan Kettering, but he started in Pittsburgh, where he was born and raised. And they will also present with lump and pain, but can also have constitutional symptoms, things like fevers, chills, night sweats, stuff like that. And this is what James described under the microscope: monotonous sheets of small round blue cells. And there are lots of things that have small round blue cells, just as Patrick said. So our friends in pathology have to use special stains and tests to say, yes, indeed, this is a Ewing sarcoma. And the way that's done mostly today is 95% of these patients have this beautiful 1122 translocation that Dr. Grohar taught us about. And that's how we cinch the diagnosis most of the time. Okay, so if we look at the treatment schemas of these 2 diseases, the way I describe it to my patients is it's a surgery sandwich, or like a hamburger. The top bun being chemotherapy, the bottom bun being more chemotherapy, and the middle being surgery. So as you can see from this schematic, you get preoperative chemotherapy, which is about 10 weeks, followed by your surgery, followed by more chemotherapy. Now, there were or are still a few audience members from the chondrosarcoma community, and I left that disease out. In retrospect, that was probably stupid, because if anything is the poster child to talk about surgical decision-making, it's chondrosarcoma. And the reason for that is because, among other things, in chondrosarcoma, we can't rely on chemotherapy or radiation to bail us out as surgeons, okay? Because they just don't work. Chondrosarcoma is a surgical disease, meaning if I can't cut it out, it's not going to go well for the patient. But all that aside, this is the way the treatment of osteosarcoma and Ewing sarcoma pretty much happens all over the globe. What does this mean? After undergraduate at Notre Dame, go Irish, I had 5 years of medical school, followed by 6 years of residency, followed by 1 year of fellowship. So that's 12 years. I had 12 years to learn how to do these operations, what their advantages and disadvantages were, what all the nuances were with them, and everything that goes into making the decision about what I think is going to be the best choice for the patient. I got 12 years to do that. Patients and their caregivers, they get 10 weeks. Not very fair. Not very fair. Let's talk for a second about another thing Dr. Grohar mentioned. That's the concept of margins. This is sort of the guiding principle of sarcoma surgery, imperfect as it may be. So if you think of the sarcoma as an orange, the actual tumor, the part that we eat, is the fruit. Well, to keep that analogy going, if I go in there with my melon baller and I just scoop out the tumor, no matter how meticulous I'm being, no matter how careful I am, I will leave sarcoma cells behind, guaranteed. No bueno, not okay. This is an everything must go sale. that's not okay. I have to remove 100% of the cells. So how do we do that? How do we make sure that there's none of the enemy left on the battlefield? Well, we put a peel on it. And that is normal patient in 360 degrees in 3 dimensions all the way around the tumor. So we insulate it with normal patient tissue. So in sarcoma surgery, do we do intentional collateral damage? The answer is yes. Do we feel bad about it? I don't know about my partners. I feel bad about it. Do we apologize for it? We do not. Because in 2025, that's how I know that I'm getting the whole tumor out. Now, so with that being said, what are some strategies that we can apply that are going to achieve those negative margins for that patient? Because we know that got to happen. Now, how are we going to do it? Well, there are 2 basic flavors of how to do that. The first is with amputation, which is divided into 3 major flavors: transfemoral, literally above or through the femur, above the knee, also known as amputation; transtibia, through the tibia, so below the knee; and rotation plasty. We'll talk about rotation plasty in a second. It's a very unique and creative solution that basically turns a above the knee amputation into a below the knee amputation, and we'll explain why that's important too. In limb sparing surgeries, there are 3 main options. Endoprosthesis, which is that you're going to take out a chunk of skeleton and replace it with metal and a modular endoprosthesis. With allograft, which is a piece of cadaver bone that you're putting in place of what you took out. And I have this asterisk here for autograft. Now, in most in the United States and most of the Western world, we use one of these 2 strategies, either a megaprosthesis or an allograft. Not everybody in the world has access to a $25,000 modular endoprosthesis or a large allograft bone bank. Okay? So in some parts of the world, what they'll do is they'll take out the tumor with the bone on it, and they will kill the tumor cells with either cooking it in an autoclave and then putting it back in, or dunking it in liquid nitrogen, killing the cells by freezing them, and then putting it back in. This is not part of my training or my experience, but just to have a complete discussion, in some parts of the world, this is how they crack that nut. Okay, here's an example, just taking them by the numbers, of transfemoral amputation. This on the left there, that's what it looks like. And here's what the x-rays look like. This is the top part of the x-ray. That's the hip joint. And then there's the cut end of the femur. Some people, myself included, find the use of the word stump insensitive. To each their own. I prefer residual limb, but everybody's got their own opinion about that. Below the knee amputation or transtibial. This is what the patient's leg looks like on the left there, and this is what the x-ray looks like. You can see there's the knee joint, the tibia has been cut, and also the fibula. Why is that important? Why does it matter? If you have a biological knee joint, the energy expenditure and the function are far, far, far superior than not having a biological knee joint. And as an extension of that, let's talk about rotation plasty. This is a very creative solution. And as I said, a way to convert a transfemoral amputation into a transtibial. So how do we do that? Well, let's say that you're a 5-year-old kid with an osteosarcoma in your distal femur. What we can do is cut the femur above the tumor, cut the tibia below the tumor, and basically take all that bone out, take the knee joint and the surrounding tumor out. Then what we can do is spin the foot and the calf 180 degrees. So now instead of the toes pointing forward, they point backward, and put them back on the femur. Sounds a little bit crazy. It looks a little bit crazy. It is a little bit crazy. But what does this accomplish? The ankle now becomes your knee joint. Okay. It isn't the same as the knee joint you were born with, but it is a biological knee joint over which the patient has control by virtue of their intact nerves and blood vessels. So this is a very creative solution, and when they work great. Okay, so just wanted to editorialize for a minute on amputation. Sometimes the tumor dictates what you're going to do. Right? There's just no potential for limb salvage because the vital structures of the lower extremity or the upper extremity, the nerves and vessels, are too involved, you cannot do anything to get those negative margins except amputation. That's okay. This is a viable reconstructive option. This is not some sort of defeat. Okay, so this stigma needs to go away. The good news and the bad news is that amputation can't be reversed. So all of those examples we showed of, or in the ones we're going to show of the joint preservation or the limb preservation surgeries, the limb salvage, they can be revised or taken back to one extent or another. I can't take this back. I can't have a patient say to me 6 weeks after surgery, you know what, Weiss, I really don't care for this. I want to go back to the way I was. I can't do that. So obviously, this is a discussion you have before surgery and not after. Okay, let's talk about limb sparing. So the two major strategies that I use are either an allograft, which in my hands, I don't do osteoarticulars, meaning that the joint is involved, but you can. There are still places that do that. You're using a big piece of dead bone as a scaffold for what you took out, which is fixed in place to the remaining skeleton by a rod or plates or both, or a modular endoprosthesis. And one of the benefits to that is your leg doesn't look like this, your leg looks like this. It looks essentially normal, except for a big scar. Okay, so let's talk about these options. All of these will work by achieving those negative margins. Okay, all of those will check that box. All of these have advantages and the potential for success, however you measure that. All of them can go really, really badly. They can all have complications. All of these are my x-rays. Okay, so my first surgery was the osteoarticular allograft done by Dr. Mankin in Boston, and that fell apart, then got infected, then fell apart some more. And then Dr. Goodman performed a series of modular endoprostheses on me. This is one of them. And after a number of failures and about 25 operations over 8 years, I said, I don't think I can do this anymore. And through shared decision-making, he and I decided to go to the option on the left there, the transfemoral amputation. All of these could be the right answer for a particular patient. So given that they're all going to give us our negative margin and they can all be the right answer, how do we decide what to do? This is a wonderful quotation from one of my marvelous mentors, Dr. Carol Morris, who's at Sloan Kettering. The most nuanced part of what we do is matching the right operation with the right patient. There are lots of options. They all work okay, but if the patient doesn't want it, it doesn't work at all. So how do we dig deeper into that and do shared decision-making? Enter the osteosarcoma decision aid that is the brainchild of Dr. Pannock. This provides sort of a helpful framework for how we're going to start having these discussions so nothing gets left out and everybody leaves the discussion with the information they need to make these difficult choices. And there's the link to the decision aid. And I think also Dr. Pannock has brought some cards. Super. Okay, so what has her research shown that the patients need? They need more information. They don't feel like they know about long-term outcomes, functional limitations, and potential complications. Providers have their own set of challenges. The biggest one for me is staying unbiased, and we'll talk about that in a second. It's difficult to find that sweet spot of giving the patient and the patient's advocates all the information we think they need and not completely overwhelming them. And also time constraints. We'll talk about that in a minute. The patients and advocates have their own set of challenges, and this is by no means a complete list. This is an emotional time for a patient and her advocates. Weighing things like appearance versus function, poor understanding of the long-term outcomes and the need for rehab. I want to talk about bias for a second. So I just want to, I hope people understand how desperately the surgeons want to do the right thing for the patient and their advocates. There's nothing we want more than that. And we know what we're good at. We know what solutions are good in our hands and what's had success and what's had the opposite of success. And so we naturally, because we want to do right by the patient, we gravitate towards those things. But here's the but. That doesn't take the other options off the table. And we got to remind ourselves, it ain't your leg. It's the patient's and the advocate's leg. And we'll talk about that more right now, I guess. So this can require some humility and some creativity. So here's an example from our practice. On the left is my partner, Dr. Stella Lee, who took over Goody's practice. And I'm on the right there. And then the middle is Dr. Megan Anderson. So Stella had a patient early in her practice, 5-year-old with a distal femur osteosarcoma, a lot of discussions, a lot of research. We think we would like to do rotation plasty. Okay, well, Stella hadn't done any yet by herself in her practice, and I had done one, and it went horribly. So what did we do? Well, we called up Dr. Megan Anderson from Boston Children's, who is one of Stella's fellowship teachers, and we brought her down to Pittsburgh. And the three of us did the case, and it went spectacularly. So sometimes you got to be a little bit creative and a little bit humble. We've heard this a lot today. We need to do a better job of using plain language. We need to do a better job of articulating complications. Liberal use of illustrations, animations, videos. There's lots of great resources on the web. We had our friend from Vancouver who spoke about patient stories. This is so important. Ideally, you would, as a surgeon, you would have a list of resource patients that you can point people to and their families. When I was trying to decide if I was going to have my amputation or not, Dr. Goodman hooked me up with a guy who had a transfemoral amputation, who could tell me the good, the bad, and the ugly. Okay. So those stories and being able to say, hey, don't take my word for it. I can do the surgery. You want to know what it's going to be like? Talk to this guy. That is very valuable. We should do a better job at that. We want to clearly state the risks, immediate and long-term complications. And this is a balancing act too. We're dealing with a young person and their family who are not at their best. They're probably going through the worst part of their lives. You don't want to kick the kid when he's down. But at the same time, we can't sugarcoat the reality of these options. And that's hard. Timing. To the previous point, this is probably not a conversation or a set of conversations that you want to have after you just told a 13-year-old that they have a life-threatening illness. This is probably something where all you want to do is sow the seed and set the table for future discussions. This is what's going to happen. You're going to get some chemotherapy. Then we're going to do surgery. We'll talk about the details of that sometime in the future. Just know that it's there. It's part of the treatment and you have options. And leave it at that and save the rest for a later date. There are practical challenges. So my challenge as a surgeon is I got to do all those things, right? I got to have a thorough, nuanced conversation about the risks, benefits, short-term complications, long-term complications of each procedure, allow plenty of time for questions and answers from everyone in the room. By the way, do that in 15 minutes when the patient's on the floor crashing, the OR is calling you, the residents are nowhere to be found, and your family's pissed off, probably because you're working 80 hours a week. And it's no easier for the patients. In fact, it's harder. Without any medical background, you need to have a complete bomb-proof understanding of these complex surgical procedures that I spent over a decade learning how to do, and ask every intelligent question and make sure that you're equipped with everything you need to make a life-changing, potentially irreversible decision. Easy, right? Oh, and by the way, Aunt Mary and Grandpa Steve have a whole litany of questions that you need to ask. And most of them are pretty dumb, but you know what's going to happen if you don't ask them. I've been there too. So the reason why these anecdotes are funny is because they're true. None of this is easy. Okay, if there was something that worked for every patient in every situation all the time, we would just do that, and there would be no reason for a conversation like this. That doesn't exist. There's no right answer. This is a one-size-fits-one phenomenon. What's going to be the best fit for this patient and their values and their advocates in this particular circumstance? That's the challenge that confronts us. In conclusion, clearly, we've got room to grow, don't we? There is a lot of room to grow for patients and advocates and us, their caregivers, to have better conversations, to match them up with the right solution that's going to be best for them, because the right answer is the answer that's right for them. And just once again, thank goodness for Dr. Pannock and her team for developing tools that are going to help us do a better job at that. Want to close, take speaker's privilege to close with a plea for something for the future. Fighting a sarcoma, as many in the room know from personal experience, is not fun and it's not easy, but it's also not complicated. You wake up, you do whatever you need to do that day to see the next sunrise, and you repeat as many times as necessary. Until one of two things happens. The sarcoma is gone or you're both gone. But if everything goes the way you want it to, then you wake up one day and there's no surgery planned and there's no chemotherapy planned and the scans are looking good. And me and Dr. Grohar are high-fiving each other because you're alive. And you're grateful. Of course you're grateful. And you're happy. Of course you're happy. But something isn't right. How do you put the pieces of a life back together when, no matter what surgery you've done, the pieces are literally different sizes and shapes than they were before you got sick? And 100% of my young sarcoma survivors go through this. I see them struggling with this. And this is where I need your help, because besides recognizing that and saying, I see what you're going through, survivorship's hard, time is going to help, you're going to be okay. Besides saying that, I don't have a good way to shepherd them through this. And if you and people like us could give me a hand with that, I'd be very, very grateful. So thank you all. There's my contact information, Dr. Pannock's, and hopefully talk about this some more. Thank you. Sir.
In this day and age of the internet, which luckily I retired before most of it existed, do you give the patients sites that they may look at so that they don't randomly pick up some site that, you know, may have been anti-vax because it caused osteosarcoma?
Right. Yes. So it's a great question. And again, ideally, you would have ready to go a list of resources that you have personally vetted, or somebody like MIB has vetted, to say, these are reliable, they're good. Go here for some information. Now, can I do anything to keep that person from finding the others? Of course not. Right. But what it's sort of incumbent upon me as the provider to make those resources easy for them to find.
So I will say that on the osteosarcoma decision aid, this isn't something that was created just by me, right? Hundreds of patients, providers, prosthetists, physical therapists, surgeons have all contributed to this, and it's been vetted by orthopedic oncologists. So there are resources in here that they're very glad that are included on here that aren't, you know, maybe they wouldn't be able to offer themselves. For example, the Facebook support groups, which are also highly vetted. These aren't, you know, I'm the moderator of two of those. So, you know, we're very careful about what gets said in those groups, but also MIB is on there, Factors on there, Osteosarcoma Collaborative's on there. All of the resources have been vetted. So this is a source that is widely disseminated by surgeons at diagnosis to sort of get that information and that conversation started.
So, the border representation that you gave, where you give the chemo for osteosarcoma patients, then surgery, then chemo. I don't know, but I have survived osteosarcoma, distal tumor osteosarcoma 4 times, and I am a rotation plasty patient, which actually you are showing. But my rotation plasty was done as a precautionary measure, so that it couldn't, so that it shouldn't metastasize to the lungs, because it has happened thrice before rotation plasty happened. But after even rotation plasty happened, it actually metastasized to the lungs, and I had to undergo chemo for the second time. But when the first time chemo happened, it was not when the first surgery was done. It was when the third surgery was done. After the third surgery, my osteosarcoma, which was exactly perosteel osteosarcoma, in which
I was gonna guess that.
yeah. So in perosteel osteosarcoma, you doesn't usually go ahead with chemotherapy and radiotherapy. But when it got triggered for the second time, again it was a soft tissue sarcoma. I was not given chemo or radio. But after the third time, it actually became high grade because the margins was positive in the histopathology report. And at that time, I was given that, okay, now you should go ahead with the chemo with IAP protocol. And three chemo cycles were given, then rotation plasty happened, and then again chemo. So that is the point that I would like to highlight here, because that was not true in my case.
Yeah, so, yeah, we were just talking about this at dinner yesterday.
Yeah.
Beware weird biology. That shouldn't have happened, right? That is what your story is. You're writing your own textbook, because that's not in any of our textbooks. And whenever I've got a patient like you, just anecdotally, who isn't following the way I think this should go, not doing we've talked a lot about the natural history of these diseases, that makes me super nervous. And so I think it's wonderful that you're here with us. And you're a guy that I'm going to follow super, super, super closely.
And one more thing that I would like to highlight here, the thing that you mentioned about patient stories, I totally agree with that. Because when I was recommended amputation, and it was just a precautionary measure. At that time, I was just undergoing chemo, and it was not in my lungs at that time. So I actually asked this one question to my doctor, which was, is there anyone else who I can see? He showed me a guy's video where he was cycling and jumping. And my only concern was I should be able to live on my own, because I love to travel the world. So I was just concerned about that, and showed me that video of a patient doing all sort of activities after undergoing rotation plasty. So I was like, that's it, I'm going for it, because I know, because before that 3 surgeries has happened, and my hip was also involved. So either I have to get rid of all the 3 joints, hip, knee, and ankle, or I could save 2 of them with the rotation plasty, and I had that option. So yeah, thank you for highlighting that.
Good. You're welcome. You're welcome.
I wanted to know your decision aid, does it take into account like cultural and myths and that? So in South Africa, we have an issue where, and it's in a lot of Africa, where it's believed that if you have a amputation, you will not be accepted into heaven. So how that could be a number one. I mean, we have patients that are or children that are ostracized from their families, and in fact they get left at the hospital on that. Is that taken into account?
It is not. I mean, the decision aid itself has only been out almost 2 years, so it hasn't been out very long. We're just getting ready to do our 2nd revision. But there are some things that have been requested, not that particular issue, but some other issues related to Hispanic traditions and things like that, where they're reluctant to do rotation plasty. So I'm working with the University of Miami to make it more inclusive in that way and change some of the images around and things like that. But I would imagine over the years, as this continues to get disseminated and used, that we'll be making some changes. But we could also, now that it's been developed and it's out there, we could adapt it to different cultural needs. So you got my email, we can talk about that for sure.
I was actually offered my own back in the hospital. And in case I needed it for religious grounds, really after the operation, I rested out there back there. It's fine. Well, you guys see not moved upon every kind of meaning, never for the letting Because, people in the villages, especially the business come from the, village area, they think that it's the women which is coming from them, and that is why we work on that. So they are actually angry with the doctor for doing the
Yeah, and that's where the patient stories are so important. So we do have a rotation plasty Facebook group. And I'm a moderator for that. I didn't start it, somebody else started it. But I mean, I work with patients and families, and believe me, every single patient and family who initially sees rotation plasty says, oh yeah, no way, there's no way I would do that. Until they learn about the risks and the benefits and start comparing all of those. So that oftentimes the kids who have rotation plasty, they can run, jump, engage in high impact activities. They're out there playing soccer, playing tennis, whereas a limb salvage that might look really pretty and look good is really not all that functional, especially for a young child who has a lot of growing to do. So that is the initial reaction for everybody. Believe me, I've been there.
So,
But I mean, if you're ostracized by your community and they don't get back into the village.
Yeah.
That's going to be a major decision point. It's not going to be like, oh, well, I can jump. I'd
Yeah.
rather not jump. than
Yeah,
do
well, that would be one of the risks that would be discussed in a
Yeah.
situation like that could potentially happen. I mean, it still happens for people with amputations as well. So my daughter is, just like Kurt, had a limb salvage surgery and 10 years later chose an above knee amputation. Rotation plasty wasn't an option for her at that point. But she still gets a lot of looks and stares and questions, and, that's one of the things that the decision may walk people through is people will ask you, what happened to you? How many times a day will they ask you? Now, in your case, I didn't know you were an amputee, that you had rotation plasty because you got it covered up with pants. So there are ways that visually you can cover it. My daughter's gait is so good that if you just see her walking, you would never guess that she had a prosthesis under her leggings or her pants. So, but it's a very individual decision. If it's a family, and a lot of kids say it doesn't matter to me what it looks like, as long as I can feel like the other kids and run around and play, so.
there are people with all of those things who do magnificent.
Yeah.
I've got a mother of three who all she does is run around after her kids because they are hellions, and she's got a limb spare. And she, can I run on this? I said, you know what, Lizzie, we can have some secrets from each other. That's okay. And I know she does because she has to. And she's doing great. She would not do as well with any flavor of amputation. She wouldn't. That's her, right? That's what works for her. And I think we just got lucky in that we picked something that ended up working so beautifully for her. But none of these are the devil. None of these are perfect. What's going to be, and if they're not going to let you back in the village, I guess you're doing a limb spare, right? So these are all the discussions that got to happen.
Probably for survivorship, one of the best things that we have found is peer-to-peer, like you said, to talk to the guy and you told what would be like after the amputation. For survivorship, I think that's probably the same peer-to-peer is probably the best thing to do because you're talking to someone who actually understands what you're going through, who actually have been there before you and has done it. Like, I would be kind of one of the first arm amputees in group. So I'm 8 years out, and then we actually have like 3 others afterwards who are now, like, one was 6 years out, and 4 years out, and one was 3 years out. So they go to me, is this normal? Yeah, it's grand, that will happen, or, probably not, you should probably go back to your doctor and get that checked, or. I think that's probably the best part of survivorship is being able to talk to people who get where you're going to. I can talk to my doctors, they don't understand my life, they don't understand any challenges or emotional changes from it, what these people do. So I think for survivorship, maybe set another patient care networks would be, the better thing today.
It's great advice. Thank you. Sir.
Kurt, in your long-term discussions, do you discuss financial matters? For instance, your prosthesis is not cheap.
No.
And when you fall in the lake fishing,
For
it needs to be
hypothetical.
fixed. Do you discuss the fact that from the time you were out of Notre Dame through where you are now, you've had certain expenses that needed to be met?
Yeah, so that's a good point too. And this gets back to our discussion yesterday, the insurance question. It's probably whether, if you're in a country that has a public and a private option, what your prosthesis looks like is probably completely different, and what the maintenance looks like is probably completely different, right? So those are important discussions to have. I will say that, yeah, you know, I've got to buy liners every year, every other year. It's $700 that insurance doesn't pay for. Any sort of modifications that I want to make things more comfortable or better, that's coming out of my pocket. You know, these are all things that need to be discussed. Whereas with a modular endoprosthesis, okay, it might cost $30,000 off the shelf, but you're done if it works. So, yeah, there is that.
I would like to add few points. I actually agree with you that the rotation plastic may not be physically very good looking. Like it doesn't look very attractive, or someone would think that, okay, is it by birth, or like how this stuff happened? But mobility is off the charts. Like I can see it myself, and I'm a type 3A rotation plastic patient, so I can vouch for it. And secondly, for the insurance part, my prosthetic is also not covered under insurance, and it takes a toll on how I have to afford it. And recently, I got a new prosthetic made, which is not to my need. So I have to go back to my old prosthetic, which is like not very good. So yeah. And the third point, which you also highlighted, that the people who are doing very good after the amputation. So and I would reflect one of the challenges that I faced after undergoing rotation plasty, and that is not a physical challenge. That's a political challenge. What I would call is that after undergoing amputation, I got back on my foot, and I won archery national in India, and I went for Paris Paralympics trial also. But I was denied entry just because I had rotation plasty, because in rotation plasty, your leg is surgically attached above. And in their rules, in the International Paralympic Committee rules, they don't account for the surgically attached legs or surgically modified anything. They just account for the cases which are by birth, the disabilities by birth or through accident. But in my case, it was attached using surgery. In some cases, athletes use it to their advantage so that they can get increased mobility. So they agree. I actually fought for it, and they agree that it's a limitation in their rules, and it will take time to modify their rules. But for the current Paralympics, like Paris Paralympics, I was not eligible, so I couldn't even got the chance to even try for it. So that is one of the disadvantages that I faced for the rotation plastic.
So I think we probably want to start wrapping up this conversation and move on to the next panel discussion, but thank you so much. And I actually just want to say also, but you had a slide up there that really resonated with me, which was like the time, like just the challenges of like how much time you have to explain these very concept things to patients. And I remember, you know, our surgeon patiently responded to like my 2 pages of like single line typed questions. If he took a valiant stab, I think he got through like half of the first page, but it's a lot. And so I think there is probably an opportunity for us. I can see like so many organizations represented on the table to kind of combine our resources. And we've talked about this a little bit, Catherine, for the Bone Sarcoma Alliance, maybe putting together kind of a centralized area of educational resources so that it makes it easy for you guys to kind of point your patients to like a, you know, a place that's already been, that's the word I'm looking for, but resources that have been vetted, right, by these different organizations. So it's like a great place for them, and not to mention just educational resources, but also connecting them with patients. I know that surgeons have their patients that they can connect their patients with, but like for disease specific areas, you can probably reach out to different organizations. Because we certainly offer that at MIB, and I'm sure other organizations do that as well. For the additional, like, tell me about your rotation plasty and how that's, you know, been working out for you. Yeah.
That would be very welcome.
Yeah. Great. Thank you.
I just wanted to add 1 second. My name's Darlene Rosestein with Pittsburgh Sarcoma. So I have the pleasure of working to provide some funding for Dr. Weiss and for his lab. So when I met him back in 2012. Yeah. In Pittsburgh, it was Dr. Weiss, another doctor in Acton. Would you have 2 cell lines? Like 2 cell lines, and maybe you had a cooler. So that way you could have like your own dedicated freezer. And through Dr. Weiss's just involvement in community and working with patients and just organizing us in general. This past year, we granted $460,000 to over 20 grants in the Pittsburgh area, which I think I just counted was 11 facilities. And that's because of these 2 right here. So just wanted to take a minute to congratulate them on their efforts. And have it here. I'll tell you about the 25 different areas of his life where he's working to cure sarcoma. All the direction of the gentleman on my right who paved the way. So congratulations to both of them.
Okay, should we kick off the discussion?
Am I doing that or are you doing that?
Oh, yeah, you can throw out the question.